Hey everyone, and welcome back to PS Platypus. We all hope you had a lovely semester break. We're going to be starting off this week's clinical skills with the reproductive system, talking about history, examination, investigations, as well as a bit about contraception options, because you're going to be expected to be able to understand how that works for both your exam when they have EMQs about contraception options and choices, as well as for the OSCE, where you'll both be expected to explain how contraceptive options work and also be able to explain specifically how the COCP works to a patient. So without further ado, let's get started. So it's really important that you are able to take a good reproductive history. And we have a common component to the history, which you would ask everyone. And that involves asking about identity, so gender identity and sexual identity, as well as about sexual activity. So asking about how many partners they've had, type of intercourse they've had, whether they've been using protection, as well as if they're using contraception, what types they're using as well, because all of that can have very important implications for the health, namely STI screening, and also certain medication options they might be using for contraception may be explaining why they have certain symptoms like heavier or lighter periods. Next, you have STI screening again, but this time instead of asking about protection, you're asking about IV drug use, tattoos, and piercings, all because they carry the risk of bloodborne diseases if they're not in hygienic conditions or if you're needle sharing. Um, then you also want to ask about general genital changes, so things like changes in libido or sex drive, any pain on during sex called dyspareunia, urethral or vaginal discharge, again, highly important to ask about because that can be linked to STIs or other pathologies. Skin changes as well, so rashes, lesions, ulcers, blisters, again, very much STI related, but can also be important in other autoimmune pathologies. Um, and the next component we have is then the gynecological history, which would ask of patients who have a uterus. And so you'd ask about the menstruation, and that's when they've had their most recent period, so their last period, as well as the first period they ever had, which is called menarche, the age of onset of periods. Then you also want to ask about cycle length and regularity, whether they're having whether they're having normal flow, the duration, the amount. If it's abnormal and it's very low, it's called amenorrhea. If it's very high, it's called menorrhagia. Um, whether they're having any pain as well, which is very common, and that's noted as dysmenorrhea. Then you also have obstetric history. So you want to ask about GNP, so gravida and parity. The G component of gravida refers to how many times they've conceived, so they've been pregnant. And then the P component of parity refers to how many times they've actually delivered a baby, whether that be stillborn or live birth. And then you can also ask about more questions regarding birth, so any preterm and versus term births, any abortions, and then finally, any living children they have, and then their current state of health. Then we come to genitals, and we've already asked a bit about that in the common history, but again, some other additional questions you might want to ask, which you can ask anywhere, would be pelvic pain, any discharge, again, if you already asked that, there's no point asking it here. Any urinary symptoms, again, you could have UTI symptoms that are manifesting as pain during sex, or that might seem like STI symptoms, or there could be a UTI and STI mixed picture going on. You also have erectile dysfunction, important to ask about. It shouldn't be there. It should be in the urological history, but we'll come to that in the next bit. Screening also, you have your pap smear and breast exam. So it's important to ask if they've had those screening tests done regularly like they should, and what, if any, there were significant results there were. Then you have urological history, testicular pain or lumps are common presenting complaints that you want to ask about and elicit more details about. And then you also have sexual problems, so erectile dysfunction. This is where it should be asked. And then you also have premature ejaculation. Is another thing you might want to ask about. Again, we'll move on to the clinical correlates, because it's probably the most important slide to take away from all the slides that we have today. Because in the setting of both exams where you might have EMQ questions about reproductive pathologies, but also in the setting of an OSCE where you might have someone presenting with a complaint and you have to be able to list some possible differentials for what they might be having, it's important to at least have a couple of pathologies in mind. And these are ones that I think are more commonly assessed and commonly asked about. So it's important to at least be aware of them, and then learn a bit about their signs and symptoms, and investigations. Keeping in mind, all of these will be covered in due time in your physiology lectures and your microbiology lectures. So just have an idea of them. And if you ever need to come back to the slide for the examinations or for your OSCEs, they contain the important pathologies here. So starting off with pathology 1, premature menopause. With this, you'll commonly have someone presenting with irregular or even ceased periods. They might complain if they have premature menopause of hot flushes, formication, which is just describing an itchy sensation, which can often be, again, described in their words as ants or insects crawling across their skin. They might be more irritable. They might have weight change, which is important to ask about. And then investigations are on the right there. PCOS, again, you learn about this in due time, but some common presenting complaints is, again, you might have amenorrhea or lighter periods. But besides that, you also might have hirsutism, so male pattern hair growth, weight gain, acne, infertility, all because of the elevated level of androgens. And then with your STIs, you'll learn over here in microbiology about more specific signs for particular types of STIs. So I won't go over it here, but some general things to keep an eye out for is with the genitals, whether they notice any changes, namely discharge is a big one, whether there's any pain in that region, any lesions, and also any UTI symptoms that might seem relevant. In terms of investigations, swab or PCR or sort of culture even could be important to get done. With pregnancy, again, they might present saying, I've missed my last period, they've had ceased or irregular periods, and then on examination, you look for things like, again, depending on how far along they are, weight gain, skin striae, which is again from the skin in the abdomen stretching, and then having those stretch marks there. The belly button will usually point outwards as opposed to inwards in the case of obesity. And then they could have a pelvic mass as well. An important investigation to keep in mind here is your beta-HCG or your pregnancy test. And also you can do an abdominal or pelvic ultrasound to rule in pregnancy. Pituitary adenomas, over here with history, you'll probably have them complaining of bilateral galactorrhea, so milky discharge from the nipples. And this is often because there's elevated level of prolactins being produced by that tumor, which is causing the breast tissue to be producing this much milk. And then you also have another result of the space occupying lesion in their brain, which is a visual field defect. You won't learn too much about this at this stage, but you'll learn more about how it manifests during head and neck later on the semester. And you'll learn exactly how it's pressing on particular optic nerves nearby and causing these symptoms to appear. So I won't cover it too much, but they might just complain of a visual field problem. And then varicocele, again, it's not too much covered in clinical skills, but I think it's an important one to keep in mind because it's quite a buzzwordy presentation. So commonly, patients will describe it as a bag of worms sensation because essentially you've got dilated veins and testicular region. And it's often left-sided because of the anatomy and the fact that the left testicular or left spermatic vein comes off the left renal vein as opposed to the right one, which connects straight to the IVC. And so you have that angle there, which makes it more prone to blockages and more prone to getting sort of venous congestion in the testes. And it can also be described as being worse on standing because, again, if you stand up, gravity is just going to cause the blood to pull down further. And also with Valsalva, so where they sort of close their nose and breathe through a closed nose, that pressure might cause, again, it to worsen. And in terms of investigations, you might do an ultrasound and it might demonstrate dilated vessels in that testicular region. All right, in terms of investigations, they're not too important to know about because you'll learn more about specific investigations, again, in specific lectures, but I thought I'd just cover some general ones that you might hear about, and so you can just keep them in mind. So bedside investigations for reproductive system include the pregnancy test or the beta-HCG, as well as your swab. If you have, for example, vaginal or genital discharge, you might swab it, PCR it, culture it, do whatever you want to figure out what the cause of the swab is, and it could be an infective cause. cause of the discharges, and it could be an infective cause. And then with bloods, you have hormone levels, so testosterone, FSH, estrogen, amongst a plethora of other things. We also have your thyroid function test, which might seem a bit odd to talk about here, but it's important to keep in mind as well that hypothyroidism can actually cause amenorrhea. So that's another important thing to keep in mind, is that if you have someone presenting with reduced periods, you might be thinking about pregnancy as one thing, you might be thinking about premature menopause is one thing, but also don't forget to think about hypothyroidism. And again, if you do suspect that, you want to ask about other questions related to hypothyroidism. Next up, you have imaging. So you have your abdominal and pelvic ultrasound that can be used to look for pathologies in that area. So like ovarian cancers and fibroids and cysts, and other things you might consider, as well as screening tests, your pap smear, PSA, even breast exam technically here for screening, genital swabs, and semen analysis are some other things to keep in mind. All right. Next, we have contraception. So contraception is a big one because, again, it's very important in the context of both your exam EMQs, where you have often a patient being described, and then they ask you which contraceptive option is ideal for them, or also during your OSCEs, when you might actually be asked to explain contraceptive options to a patient. Most commonly, you'll be actually asked how to explain in detail about the combined oral contraceptive pill, or the COCP. So we'll cover that in more detail at the end, but we'll first generally overview them. Now, I know that you also would have been given a very big table of all these options and how they work, all of the relevant information about them, but I sort of distilled that down into a high yield table where it covers what's relevant for patients. So we'll have a look at that as well. Here's just an overview of all of them. We'll be going into them in more detail in the next few slides. So first up, we have our long-acting hormonal sort of methods. Long-acting reversible contraceptive methods. So that's your IUDs, and you have copper IUDs and progesterone IUDs. So that's Mirena and Kylena. And the way that they work is, first of all, they act as a physical barrier to stop the sperm reading the egg, but also the hormonal one works to reduce or make the conditions less inhabitable for implantation as well. So the pros, and then you also have down below there the Implanon, which is again another viable option. It's essentially an implant that they put into someone's skin, I think usually in the arm, and it secretes again progesterone that will have a similar effect to the progesterone IUD, in that it makes the conditions less hospitable for implantation. Benefits of these are that they're single insertion, so they're quite convenient. And they're easily reversible as well, if the patient wants to consider pregnancy in the future or having children in the future. The pros of using a progesterone-based IUD and progesterone-based IUD is that it actually makes your periods lighter. So if you have someone who's got quite heavy periods and they're quite uncomfortable for them, it can actually be a benefit. In terms of cons, all of these methods offer no protection against STIs, right? Because there's no physical barrier against fluid exchange. And then procedure. And then the next thing is that they're all sort of require some form of procedure, which can feel quite invasive and be painful. So if in the STEM it describes someone as being quite averse to pain, this might be less ideal for them. In terms of other cons, so copper IUDs, it doesn't really affect your periods because, again, it's not having any hormonal effects. So it can actually cause your periods to become heavier as well, although I'm not too sure as to the mechanism of that. With Implanon, it also has this thing where it can make your periods more irregular or frequent even. And some other effects as well that I noted down there. So weight gain, sore breast, bloating, mood swings, skin changes, which you can keep in mind as well. Next up, we have other options. So these are the short-acting hormonal methods, and they include the COCP, combined oral contraceptive pill, the NuvaRing, progesterone-only pill, and the morning after pill. So starting off with the combined oral contraceptive pill, it's one of the more common options that's used. It makes, again, your periods lighter because of the progesterone and the hormones inside there. It also helps with acne, surprisingly, and it does also reduce your risk of ovarian and uterine cancer. With NuvaRing, it's a similar formulation, and it also helps with making your periods lighter. And with the progesterone-only pill, it's sort of one that's you could think about if the COCP is contraindicated, and we'll talk about why it could be contraindicated with the con section later on. And the morning after pill is really only like an emergency option after having intercourse, whereas the other options are taken beforehand prophylactically. All right. In terms of cons, again, none of these options offer STI protection for the same reasons as before. Another thing that might be inconvenient about them for patients who have a busier schedule or might not be as willing to take regular doses of something is that they can often have quite strict regimens. So that's another thing to keep in mind as well. Even with the NuvaRing, you have to get it changed every so often. And then in terms of cons for COCP and NuvaRing, there's a clotting and DVT risk. So you especially want to be careful of prescribing this or giving this to people who are smokers or who are obese, who have a greater risk. It's potentially been linked with epilepsy. It can cause migraines. It has some adverse drug interactions with St. John's wort, which is an alternative medicine used by some patients. So that's why we actually ask about alternative medicines, because it can have these interactions. It can actually reduce the production of breast milk, so it's not ideal for someone who's breastfeeding. And also it can increase your risk for breast cancer. So it's not something you prescribe in someone who might have a family history of breast cancer. With the progesterone-only pill, again, some problems that can occur is irregular frequent periods. So someone who's already got menorrhagia might not be suitable for that. It's ineffective if they have diarrhea or vomiting, so they have to take it again in the context of that. Contraindications include epilepsy as well, and St. John's wort being interacting with it. The morning after pill, it's something which can be used as an emergency option, but it's only about 85 to 99% effective as opposed to the other ones, which are much higher in their effectiveness. You need to take it pretty quickly, so less than 4 to 5 days after sex as well. All right. And then we come to a final list, which is covering barrier methods, fertility awareness-based methods, and some other methods as well. So the male condom, female condom, pros, they offer STI protection. Cons being they're single use, so you'd have to repeatedly buy them, but they're often quite cheap. And then some other cons as well is you can't use it if you have a latex allergy, latex-based ones. And then again, you can't use oil-based lubricants because it can cause holes to form on them as well. And then you also have diaphragm, lactational amenorrhea, natural family planning, sterilization, withdrawal, all of them which are described in some detail in that table that would have been given to you by faculty. But the main things to consider here for cons is, again, they don't have any STI protection. Even with the diaphragm, it sits all the way up near the opening of the cervix, so it doesn't protect the vaginal canal. And then other cons include, with the diaphragm, rubber allergy, it's reusable, which actually shouldn't be in the con list. It should be a pro. And then it also requires some education as well as to how to insert and how to use it. Lactational amenorrhea, it can only be used post-pregnancy in a particular time period where you've not had a period since pregnancy, where you've not had a period yet, and your infant is less than 6 months old, and they're only breastfeeding and not having any food or drink otherwise. So that's sort of a very strict requirement that you have to meet for it to be 98% effective. And it's only able to be using that time period. And the natural family planning, so using sort of the calendar or rhythm method, which can be quite meticulous, but it's 76 to 99.5% effective. And in sterilization, which is surgical procedure, so in males vasectomies, in females tubal ligation, a con that could be considered is it's permanent, although some are quite some modern procedures are quite reversible. And then finally a withdrawal, which is 8 to 96% effective and very unreliable. So that's contraception covered in a nutshell. And I've done it in this form so that if you have questions, again, about contraceptive choices for a patient in a STEM, you can actually look at this and look at indications and contraindications for that and link it up with that. And then finally, we come to COCP counseling, and it can come up as an OSCE station. So it's important to understand how you would approach explaining it to a patient. So number one is being able to explain what it actually is. So it's a hormonal pill containing estrogen and progesterone, which essentially prevents pregnancy. But if you want to go into more detail, you can talk about how it inhibits ovulation, so it inhibits that egg production / release. It thickens the cervical mucus, so it's harder for the sperm to actually meet the egg, and then it thins the endometrium, so it's harder for the blastocyst that forms after fertilization to actually implant in the endometrium. Effectiveness wise, it's 99% if taken correctly. Pros are that it's non-invasive, so there's no procedure that needs to be done. So if you're averse to pain, it's not really an issue there. It's very effective. And it also makes your periods lighter and more regular. So that can be a benefit if you're already having quite heavy periods. It also improves your acne as well, which is something that might actually be a different use for the pill rather than for someone who would use it for contraception. And then it also reduces your risk of ovarian and uterine cancer. But then again, one of the side effects being that it does increase your risk of breast cancer. So that's a con of it. Other cons include if you've got a high risk of clotting or DVTs, it can actually make that worse. So be careful if you're recommending it for someone who's got a high smoking history or is obese. Heart and liver disease is another thing. It can actually cause migraines or make them worse. And it offers no STI protection, which is a big one, which I want to highlight. And then you could talk about alternatives here as well. So if you want to talk about alternatives that do offer STI protection, talking about barrier methods, as well as other options overall, you can bring them up here. And then finally, we talk about instructions for actually how to use it. So it's actually relatively straightforward, but there are some caveats here and there as to what happens if certain things arise, certain problems arise. So at its core, you have 21 active pills containing the actual hormone, and then 7 inactive pills. You start in the colored section. So if you have a look down there, you can see on the packet, you start in the green colored section, take 1 pill each day until you're finished in the next packet. So pretty straightforward. Take a pill daily until you've finished it in the next packet. You also have this 7-day rule where when you're starting off on the COCP, you actually have to use the condom for the first 7 days, unless you're starting on your period, because again, you still have it might not be effective for the first 7 days. Then if you've skipped a period, then you have to skip the inactive pills and go straight to the next set of active pills. And if you've had a missed pill, if you missed one, that's usually fine. You can just take that 1 pill you've missed and continue within that time. And then if you've missed 2, so that's more than 48 hours, or 48 hours or more, then you take 1, and then you take some backup contraception as well in case the COCP is not effective during that time because you've missed the 2. Another thing to keep in mind as well is if you have diarrhea or vomiting, that can also make the pill ineffective. So you have to go back to the 7-day rule of using your condom for the first 7 days because the COCP may not be effective for that 7-day period. So I hope that was all useful, high yield and relevant for what you'll be covering in the exam and in your OSCEs. If you have any questions, concerns, or feedback, let us know in the comments. Otherwise, we'll see you in the next one.